Welcome. I am Ren, CEO of Medlink Global, and I'm really glad you're here with us today. Thank you for making the time, and we have got a very meaningful conversation ahead. Today, we were talking about anxiety disorder, a topic that both clinically significant and personally relevant to many of us, including myself. To help us unpack this, I am joined by two outstanding researchers and clinicians. First, we have our guest speaker, Dr. Jeffrey Strong today,
Thanks. It's
and
great to be here.
yeah, and my co-host, Dr. Christoph Grubb.
Glad to be here too.
I will let them briefly introduce themselves, and then I will hand it over to Christoph to lead what I already know will be a very engaging and thoughtful conversation. So, Dr. Strong, please start with you.
Thanks so much. It's great to have everyone with us here. I'm a child and adolescent psychiatrist as well as an adult psychiatrist, and most of my work really focuses on anxiety disorders. And in that regard, I like to try to understand what causes the anxiety disorders as well as how we treat them, and specifically how we can really treat each patient differently when we approach treatment.
Great, and you also work at the University of Cincinnati. Maybe you can
Good
say
point,
something
Christoph.
about your
I'm also
titles.
a professor of psychiatry, pediatrics, and clinical and translational science. I just get so excited when there's the possibility of talking about anxiety disorders.
Perfect. Yeah, and I'm Christoph Corral. I'm also both a child psychiatrist and an adult psychiatrist and interested in severe mental disorders, of which anxiety disorders are one type. And we're really glad to have you here, Jeff, because if I think of anyone being able to talk very cogently and deeply about anxiety disorders, you always come to mind. And whoever has been at different congresses and conferences also knows that Jeff is not only a great scientist and a great clinician, but also a great speaker. And we will get this liveliness and the excitement that you've already talked about right now. Maybe next slide, we can see your disclosures.
Sure.
Exactly. And maybe I also say that I work at the Zucker School of Medicine in New York and at the same time at the Charité University in Berlin. So next slide, anxiety disorders, they are, next slide, very common. They're actually a reason why we're here as a species, correct? Anxiety disorders help us to survive during the development. That's why they've been so preserved and are the most common cause of mental disorders, but they're also milder and not only more severe. Maybe you can lead us through some of the categories and what anxiety disorders are, and where normal anxiety, which is actually a signal that can help us survive, can top over into a disease.
So I think, Christoph, you're really dancing around a very, very important piece here that we struggle with as a field, which is the difference between anxiety and an anxiety disorder. And one of the things that I think is always important to think about as we begin talking about anxiety disorders is anxiety has a role. Anxiety is evolutionarily conserved. It's what motivates us to study for a test, to be on time for a job interview, to look our best before a date. That's anxiety and that's normal. What is really important for clinicians as well as others listening to recognize is that anxiety is different from an anxiety disorder. When we're talking about an anxiety disorder, we're really looking for two things. One is we're looking for functional impairment. So how is that anxiety sabotaging life, interfering with our normal day-to-day activities, interfering with our ability to enjoy ourselves with friends or go out socially? But the second part of that, what makes a disorder essentially, is the severity of the anxiety. This really needs to be severe and it needs to be nearly constant, or at least present more days than not over the course of the week. Now, as we talk about anxiety, and specifically as we think about the transition from anxiety to anxiety disorders, we can think about this as something that falls into a series of buckets. And if we can think about those buckets, on each bucket we would have painted the focus of the anxiety. So when we think about social anxiety disorder, the anxiety is focused on social situations. You see that there in the blue square on the left. So those situations where we might fear embarrassment or where we might be worried about criticism from others or how we're perceived by others. Now, in terms of social anxiety disorder, like many of the other anxiety disorders, you'll see some patterns. One is that when we look at these criteria, you'll see that the symptoms need to persist for a certain period of time. And then there's also some description of the focus of the anxiety. So let's maybe move down to the middle of the slide, separation anxiety disorder, our next bucket. If we think about that label painted on the bucket, it's separation. So being away from people that are very important to us. In children, we think about primary attachment figures, mom, dad, a guardian, a grandma, a grandpa, but it can exist in adults as well. Now, we think about the third anxiety disorder that really composes what we call the triad. So the three most common anxiety disorders: generalized, separation, and social anxiety disorders. Now, generalized anxiety would certainly have the generalized word painted on that bucket. And here the anxiety is really going to be more free floating. So these are those people that are going to worry about what's going to happen next. Oh gosh, did I say the right thing? Did I not say the right thing? Did I offend someone? Did I inconvenience someone? I just have this feeling of dread about what's going to happen next, this catastrophizing. These are folks who will often have ruminative anxiety, just those thoughts going over and over and over. They're thinking about the next day. And there are also, for GAD, or generalized anxiety disorder, some associated symptoms that go with it. We'll see sleep disturbance, we'll see tension, we'll see irritability, we'll see difficulty with concentration. Now, the last two anxiety disorders that we generally talk about, we talk about together because they often go hand in hand. And that's panic disorder and agoraphobia. So thinking about them separately here for a moment, with panic disorder, as the name implies, we have episodes of intense anxiety that generally build very, very quickly. And oftentimes in panic disorder, we're going to see very physiological symptoms. My heart is beating fast, I'm sweating, I can't breathe, I feel like I'm choking. We're also, in many of these situations, going to see a change in behavior that happens as a result of the fear of having a panic attack. And as I alluded to, that's closely linked with agoraphobia, which is that difficulty really going out or being in many of these situations where we might experience anxiety: crowds, lines, being outside the house, in a store, in an auditorium, etc. So that really is the buffet of the anxiety disorders.
Yeah, thank you very much for summarizing this so well. And there's this phobophobia that you mentioned, this anticipation of, oh my God, I will be burdened again by another panic attack, or I can't do X, Y, or Z. Just means how restrictive anxiety disorders can be. Now, the most common anxiety disorder is a simple phobia. We don't have that on here. Some people in the audience might have that. It's either phobia of heights or of bridges, or it could be elevators,
Animals, insects,
animals,
the dark,
insects,
etc.
Yeah, but that's usually more circumscribed, whereas these are less circumscribed, correct?
Right, and you raise a really important point here that I didn't even include it, yet it is an anxiety disorder. And I think one of the reasons why, perhaps unconsciously, I didn't include it is because many patients don't seek treatment for a specific phobia. And the reason is not necessarily that they're doing well or that the simple phobia doesn't bother them or doesn't impair functioning. It's that they're able to deal with it simply by avoidance. And that's one of the things that we're going to come to in a couple slides, just the role of avoidance in many of these anxiety disorders. It's often a way that maintains the presence of the anxiety disorder.
And isn't it interesting, something that may help short term then actually prolongs anxiety?
Absolutely.
But let's look at the next slide and see how common these disorders are, anxiety disorders.
So these are incredibly common, and you can see that there, roughly at some point in the course of someone's life, 24%, 1 in 4 of us may have an anxiety disorder. Now, again, that number is probably a little bit elevated because of specific phobia being counted here, as well as some probably more transient anxiety disorders that do go away. But as you can see, it's just about as common as depression. and certainly more prevalent than many of what we often refer to as the severe psychiatric disorders, bipolar disorder, etc. Now, I think another thing that's important to take away from this is that while in this slide we're looking at these disorders separately, these are often conditions that have very complex courses. So they often run together with one another. And so if we look, for example, at anxiety and depression, it's very, very common for them to be together. And one of the things that sometimes happens is if I'm very anxious because of my anxiety disorder, I feel a bit more, how would I say, a bit more demoralized, if you will, about the things that I can't do because of my anxiety, and that may cause me to feel depressed. Now, that's a situation where we have overlap between the disorders, but certainly there can be true comorbidity. So I think another thing that is really, really important here is that these are disorders that are associated with a lot of other symptoms. I think it's probably worth us maybe talking a little bit more about the prevalence here if we move on to the next slide.
Yeah, let's do that, because the question is, are we improving? Are we getting better or worse?
Right. And this is something that certainly has been affected probably by the pandemic, although I think there's probably also been a recalibration in terms of how we think about anxiety in general. And that probably has conflated some of the numbers that we're now seeing in terms of higher prevalence of GAD in particular. What we are seeing is there has been an increase in generalized anxiety disorder, although largely many of the disorder prevalences have been relatively constant over time. The other thing that I think is important to mention on this slide is that because of the early age of onset for the anxiety disorders, these are disorders that strike early and they're persistent for many folks. So what that means is that these are disorders that are occurring during many of our prime years, adolescence, early adulthood, middle adulthood, etc.
Yes, and there can also be then this double hit of depression and anxiety. Next slide, where we see what comes first, and then it might fuel each other, correct?
Absolutely. And as I alluded to, oftentimes we'll see the anxiety disorders precede mood disorders, which is really interesting because for years we've screened for depression in our primary care settings, yet only very recently were there recommendations to start screening for anxiety disorders. In fact, only within the last couple of years did the USPSTF recommend that screening. But I think also important for those individuals who may be working or familiar with primary care settings is that these patients are really going to present with increased medical comorbidities. They're going to have higher rates of diabetes, heart disease, hypertension, etc.
Now, everyone here has been anxious in their lives. Anxiety might be protective, and we might have also a temperament that is a little bit more timid or holding back. But how does this then become a cycle that ends up being a disorder? Let's go 2 slides forward and review that, because that might be very interesting to the audience.
Absolutely. So when we think about anxiety, again, remember, anxiety can be completely normal, right? So when we think about any situation in which we might encounter anxiety, this is independent of having an anxiety disorder. Let's think about a child or adolescent. So a child or adolescent who has some new opportunity, maybe to try out for the play. So if we think about that new challenge, it may cause some anxiety. That in essence is normal. However, if we avoid or escape that activity, I'm not going to try out for the play, I'm going to try to get out of giving this oral presentation, acutely, it makes the anxiety less. The problem, though, as you very nicely pointed out, is that it perpetuates my anxiety. So now the next time I'm in a situation, I know that I can avoid that situation and reduce my anxiety.
Yeah, so it's interesting. My younger daughter had a period where she was somewhat anxious. She asked, well, what if there's lightning striking? And also didn't want to cross a bridge. She basically threw herself to the ground. And instead of walking away with her, we just did the opposite, exposure. taking her, saying, this is fine, let's walk over the bridge, and then that is extinction, correct? If you face the fear in the context of help and confidence, that's one way of doing it, and we can do obviously psychotherapy with it. So avoidance is not a good thing, is that what you're telling us?
Avoidance is not a good thing, but let's dive into what you experienced and kind of worked through with your daughter, which I think is something that many of us as parents have done. So if we look at the next slide, let's talk about how we learn to be fearful. So when we think about extinction learning, really what we're talking about is we're talking about how we predict what's going to happen. And so one of the things that we actually want to happen is for there to be a mismatch between what we expect to happen and what actually happens. So in the case of your daughter, she may have been thinking, if I walk across this bridge, I'm going to get struck by lightning and I will die. But what you did with her, in a safe environment, is that you walked across the bridge with her and she did okay. She was still holding your hand. She was still doing okay. She didn't have a panic attack. She didn't die. So what happened is what we call a violation of expectation. So what she expected to happen did actually not happen. So in essence, what's happened is by not doing the avoidance, we're able to change our expectation and extinguish that fear or that cognitive process that subserved that anxiety. And we see that here illustrated in the slide. If I'm thinking that this dog is definitely going to be running at me and try to bite me, and then I'm in a room with the dog and the dog is happy and wagging its tail and panting, it starts to change how I'm thinking. So now I start to try to change how I'm looking at that dog in terms of it might actually not be vicious. It might not be planning on attacking or biting me. So over time, we've changed that expectation.
So this is a very important point. We can change our expectation. However, when we're anxious, we're definitely not at our best. We may not be able to recruit our thinking. Oh, yes, this might just be a dog. I've already stroked it in the past. No, we actually mess things up for ourselves and becomes a self-fulfilling prophecy because we may stumble and then the dog gets surprised and actually gets at us. So we need to deal with that, correct?
Absolutely. And this is why when we're doing this work in what we often call exposure-based psychotherapy, we're focusing on easy wins, right? So if a person is afraid of snakes, we're not going to put them in an aquarium full of snakes, right? We're going to think of some situation in which they might be looking at a picture of a video and they might expect to be anxious. But what we want to do is to show them that they can tolerate that distress and that nothing will happen.
So that's exposure therapy, which is graded exposure. People have like anxiety hierarchies, and then in a safe environment, visualize things and get anxious, but can calm down again. So let's go 2 slides forward and see some of the treatments that are non-pharmacologic before we go into the pharmacologic.
Yeah, absolutely. And many of these will be familiar to people listening because we often use these in terms of just taking a deep breath or trying to calm ourselves down or distract ourselves in terms of thinking of something else. There are also a number of relaxation strategies that have been used for anxiety in terms of yoga, in terms of guided meditation, mindfulness-based approaches as well. But we also do have some dietary interventions. There are some dietary patterns that have been linked with anxiety. Now, I didn't say anxiety disorders, I said anxiety, but we often in this situation allow some blending here. But we also know that there are specific aromatherapy components that probably have very specific mechanisms by which they can affect GABA, which is one of the inhibitory neurotransmitters in the brain. And then more recently, guess what, Christoph? There's an app for that. We have apps and app-based treatments. So let's maybe move on to the next slide and talk a little bit about some of the medication treatments that we have. So when we think about the treatment of anxiety disorders, this is largely something that has not changed for the past 25, 30 years, really. So we have benzodiazepines. So those are the medicines that we often think of like alprazolam or lorazepam or clonazepam that work very, very quickly. And you see that there in the red. They generally, upon first starting them, quickly reduce anxiety, but long term, they do have some side effects. The probably first line medication treatments that we generally use in adults are the SSRIs, the selective serotonin reuptake inhibitors, as well as the serotonin norepinephrine reuptake inhibitors. And then we do have other options later that perhaps have more side effects or haven't been studied in as rigorous of a manner.
So let me understand this. Benzodiazepines are quick but have problems long term. What are these problems? What are the side effects you're talking about? Are they easy to get and prescribe?
So there are certainly controlled substances here in the United States. So there are some additional barriers to go through. We often do find ourselves a bit more hesitant to use them in situations where someone may be more likely to become addicted or to have substance use disorders. The other thing that I think is important with regard to the benzodiazepines is that they can be associated with a lot of sedation and tiredness. They may affect our thinking. They may, in general, just kind of slow us down a bit.
Okay, but then you said SSRIs. I get that serotonin is relevant to combat both depression and anxiety, so you can even hit two birds with one stone. But now you're telling me about SNRIs, noradrenaline. I thought when I'm anxious, I get an adrenaline surge. I don't want that. Why would I use an SNRI, and what doses do I use them?
It seems almost paradoxical. So when we talk about the serotonin norepinephrine reuptake inhibitors, it's important to remember serotonin is part of that name. So they are affecting serotonin. The other thing that I think is very important here when we think about norepinephrine is that, yes, we think about the SSRIs and the SNRIs as acutely increasing serotonin and norepinephrine, but long term, there are many different changes that actually happen as a result of these medications being on board. The other thing that I think is very important is that when we think about the three most common neurotransmitters that we often focus on in psychiatry, serotonin, dopamine, and norepinephrine, is they are intimately related to one another. So as we affect serotonin, we almost invariably affect dopamine and norepinephrine. Similarly, for norepinephrine, we will affect serotonin as well as dopamine, probably to a lesser extent.
But SNRIs, also endorsed more modestly, have mostly a serotonergic effect, and you get more noradrenaline at higher doses. That's another way to play around with this. But often we treat, and then it doesn't really retreat. The anxiety doesn't go away. So what about treatment-resistant anxiety? Let's move 2 slides forward.
This is a really, really good point that you're raising. We often, when we're looking at these clinical trials and we're seeing graphs like the ones that I just showed you, where patients are improving over time and we see symptom reduction, that's the average response. That's not every patient. This is like the going to the car dealership and hearing your actual mileage may vary with any of these treatments. And that's exactly what happens here when we're thinking about patients with treatment-resistant anxiety. We know, depending on the studies, that as many as 2 in 4 patients will not fully respond to a medication or psychotherapy for anxiety disorders. So this is something that's really, really common. And this is something that has kind of perplexed me, Christoph, because, when we think about, many of the conditions that you often focus on, depression, schizophrenia, bipolar disorder, we have defined treatment resistance for what? A decade, 2 decades, 3 decades? Treatment-resistant anxiety was first defined within the last decade, despite this being one of the most common disorders that we treat in psychiatry. How did we define it? Well, it's the failure of at least one first-line treatment, psychotherapeutic, as well as psychopharmacologic. And then as we talk about the general criteria for the anxiety disorder, we still have to have those moderately persistent symptoms and the impairment. So it's failure of treatment and the persistence of symptoms. And as you can see over there on the right-hand side, many individuals over time will improve. But unfortunately, treatment resistance is going to be very, very common, and these are often going to be recurrent conditions as well.
Can you tell us what increases the risk of treatment resistance then? Next
So there
slide.
are some factors that do increase the risk of having treatment-resistant anxiety. We can think about these in terms of comorbid conditions or psychiatric factors. So certainly having an ongoing substance use disorder is something that'll decrease the effectiveness of almost all of our treatments and worsen outcomes in psychiatry. We can also think about other factors that may be causing or contributing to the maintenance of the anxiety. You and I are both child and adolescent psychiatrists as well, and we often think about our patients in terms of the family environments. So if I have a family environment that allows me to avoid anything that makes me anxious, that's going to perpetuate some of that treatment resistance. And then we can think about things like personality disorders or co-occurring ADHD or trauma, abuse, even overlapping post-traumatic stress symptoms. We also do think about various medical causes of the anxiety in terms of abnormal heart rhythm abnormalities, what we call the tachyarrhythmias. We think about thyroid disease, and everyone thinks about this stuff, the coffee. And really, when we look at the evidence for caffeine causing anxiety, it doesn't seem like that's actually the case in the majority of patients. There are some individuals who are very, very sensitive to caffeine, but it's not a universal truth that caffeine causes anxiety. Certainly, we do have other medications, and of course, marijuana or cannabis.
Well, but that's often used as self-medication to treat anxiety. Doesn't that also cause anxiety?
It does. And this is, again, just like that avoidance that we talked about earlier that helps us maintain anxiety. So one of the things that we know from at least 3 prospective studies is that cannabis does, for some individuals, particularly cannabis that has high CBD content, lower the anxiety. However, when we look at outcomes in the long term, they tend to be far worse in individuals, particularly those that are heavily using cannabis.
Very interesting. Now let's go through a couple of slides and you tell us about which medications to use. Are they equal, at least at group levels? Do we always combine medication with psychotherapy? What's the best strategy also for individual anxiety disorders?
Really good question. And so when we're, again, looking at those first line interventions, the SSRIs and the SNRIs, this is from a meta-analysis done by a very talented medical student of mine a couple of years ago, now a psychiatry resident. In adults, we really don't see a significant difference between the SSRIs and the SNRIs in terms of trajectory of improvement, or even how much people get better, the magnitude of improvement. That's different from what we see in kids. In kids, it's been pretty clear in a number of meta-analyses, as well as the individual studies, that the SSRIs probably produce faster and greater improvement over time.
Okay, and what about different anxiety disorders?
So with regard to, actually, maybe if we can go to the next slide here. Yeah, we see a couple things are different. So I'm going to focus in this first one on placebo response, because I think placebo response tells us something very important. One of the things that you notice here is that placebo response is very, very low in social anxiety disorder, but it is significantly more so in generalized anxiety disorder and a bit kind of in the middle, if you will, for panic disorder. So what type of anxiety you have not only affects your medication responsiveness, but also your placebo responsiveness. Placebo response is part of every active treatment response. So baked into my SSRI response is a little bit of placebo response. Baked into my benzodiazepine response is a little bit of placebo response.
Okay, and that means placebo is also the environment. So we can help patients by making them more hopeful, maybe avoiding the avoidance and having some exposure. But when something works, how long should we then actually keep going?
Well, let me take a second there, Christoph, because I want to push back. I don't think that it's all entirely environment and psychoeducation. One of the most important drivers of placebo response that we see in the anxiety disorders is actually expectation. So how much I think a treatment is going to work actually accounts for about 20% of how well that treatment works.
Absolutely. But it's good to install hope, which is expectation of
Absolutely.
something working. But when it has worked, next slide, should we continue? Is there a risk of relapse? How do we deal with that?
There is a risk of relapse. And this slide is really probably one of my favorite studies in psychiatry because it answers a really important question. One of my top 20, I'll say that. So it answers a really important question that we don't often ask. And so what we're seeing here is, what's the outcomes if I treat a patient for 6 months versus if I treat a patient for 12 months? So this is not looking at, does the medication, which in this case is venlafaxine, work or does it not work? It certainly works relative to placebo. But what we see is that if you treat for a full 12 months with the medication, you essentially have cut by 50% your risk of relapse. So again, take-home message for clinicians in the audience is that if I'm treating with a medication, treat for 12 months, not 6 months.
Okay. Now we've talked about SSRIs, SNRIs, but there are also antipsychotics that were developed first for psychosis that have at lower doses other effects. Next slide. So the PENS, tell us about that.
Yeah, so many of the atypical antipsychotics or second generation antipsychotics or mixed dopamine serotonin receptor antagonists, depending on the terminology that you like to use. Several of them have been studied in the anxiety disorders. They've been studied in treatment-resistant anxiety. They've been studied as an add-on treatment. And in general, they do work. The reason that we don't tend to use them as much is because they often have a lot of baggage. They tend to have more side effects, more metabolic and weight gain side effects than we often see with the SSRIs. And certainly I know that this is your area of interest, Christoph.
Yeah, so definitely quetiapine, even at low doses, 50 milligrams and below, has cardiometabolic risks. We have other atypical antipsychotics that work for depression and have anti-anxiety effects, whether it's the partial D2 agonists, aripiprazole, brexpiprazole, cariprazine, or even lumateperone, most recent agent. But there are also other approaches like pregabalin, lavender oil. Tell us about that.
Yeah, let's move on to the next slide and talk a little bit about pregabalin. So pregabalin is actually approved in Europe, where you are at, I believe, right now, for the treatment of generalized anxiety disorder. It's not approved for that in the United States here. But one of the things that we know is that pregabalin does significantly decrease anxiety. It actually does so very quickly in many of these patients. And so you're seeing that there in terms of just the difference between pregabalin and placebo over time in patients with treatment-resistant anxiety. The important thing probably to take away from this slide is that, again, like we saw with the benzodiazepines, but not with the SSRIs and SNRIs, we actually see early improvement. So this is something that produces a faster improvement than some of our traditional first-line agents.
Does that come at the risk of abuse? And what about gabapentins, same family?
Yeah, so gabapentin has been studied in several of these trials. What is interesting is that the gabapentin trials, only one is kind of equivocally positive. The others are not. It certainly is used a lot, like pregabalin off-label. There are differences in terms of bioavailability of gabapentin and pregabalin, but it has been a bit odd to me why it seems to not work as gabapentin, but pregabalin does seem to work here.
And it doesn't have the benzodiazepine effect on being dopey, not being able to drive as much, or being related to dependence.
Yeah, it can have some of that slowing effect as well. It can also be associated with some peripheral edema as well as weight gain. And the weight gain here can be very substantial.
Okay, well, what about lavender oil? I would have never thought of something like that being good for anxiety. Next slide.
Next slide. So lavender oil is really interesting for a couple of reasons. So one is that it actually has almost the same mechanism of action as pregabalin and gabapentin, which is really interesting. And not surprisingly, this is something that has been studied in a number of prospective randomized controlled trials against placebo and against some of the SSRIs. And what we see, as you can see on the right-hand side of this slide here, is that we do see improvement over time. This does tend to work in a faster way, perhaps, than some of the SSRIs. And it also does have dose-dependent effects. So the higher doses tend to be associated with a bit more robust improvement.
But this is also available medicinally. It's not just you get it like with a couple
It
of
is,
drops.
and this is not kind of sniffing lavender. This is actually an oral administration of siloxane, which is a component here of the lavender oil.
But this is certainly not something we would start with. An SSRI is standard if psychotherapy doesn't help.
Absolutely, absolutely.
Okay.
Great point.
What about kava? Next.
Yeah, kava is a really interesting compound. And this has been studied in a number of RCTs. Not all have shown benefit, although this is something that a lot of folks do go to. If individuals are going to recommend this in their practices, I would absolutely get a hepatic profile or liver panel or transaminases, because this is a compound that was actually taken off the market in the early 2000s. One of the issues is that when the kava is actually harvested, either one component, the rhizome or the actual plant, can be hepatotoxic. And so depending on the way in which it's cultivated or processed, if some of that hepatotoxic component makes it into the actual product, it can be associated with hepatotoxicity. And in a number of those cases, it was actually fatal.
Wow. So we're only including this for completion, not for recommendation. Let's come back to one of the most used components, and that's benzos, the pros and cons. Next slide.
Absolutely. And we kind of already talked a little bit about this. The benzodiazepines certainly can be helpful. They work very quickly. They work in a number of individuals, but this is really not meant to be an infomercial for benzodiazepines, because like any class of medications, they do have disadvantages. As we talked about, they have some risk of sedation. There's some memory impairment. Now, interestingly, there was concern about them increasing the risk of dementia. That's actually probably been debunked at this point based on a number of studies. It was probably the anxiety that was actually driving that risk. There is some concern about fracture risk, and as we talked about, the possibility of abuse or dependence. But if we look at the next slide.
But in elderly patients, I mean, there is an association with mortality and also in schizophrenia. So we have to be really careful and not use it long term unless it's really necessary.
Absolutely, we do. And like any medication, we, I think, need to continually evaluate, is this medication doing what we need it to do? Has it outlived its original purpose? Is it causing side effects, etc.? Now, we talked a little bit about, at the very beginning, my personal area of interest, which is how do we individualize treatment? And this is a meta-analysis that was published a couple of years ago by our group. And what we did was to actually look at the dose response in these patients. And this is kind of an interesting finding. Many individuals are treated with these very high doses of benzodiazepines. And you can see that as the kind of brown line at the very top on the right. These folks don't get much improvement. They actually just experience side effects or sedation. Whereas if we look at the kind of medium group, they're doing better than the high dose group. But really where probably the best use of these benzodiazepines is less than 3 milligrams of lorazepam equivalents per day. So actually lower doses of the benzodiazepines certainly are associated with better tolerability, but may in fact actually work better as well.
Okay, so I'm not sure whether you want to talk about the next slide or we go right to the algorithm. What do you think?
Let's go right to the algorithm. I think we've really covered this here.
Good.
So in terms of, this is really something that's focused on the pharmacotherapy aspect. So SSRI, SNRI, psychotherapy, we often sequence them. If we get a response, it's great. We celebrate, we have the cookie cake, everything is good, we continue. However, in those situations where you have a non-response, oftentimes if it's an SSRI, we might be thinking about another SSRI or SNRI. But in those patients who have a partial response, that may be a situation where we're thinking about adding something. Again, we don't want to lose what we already got from the initial treatment. We want to augment in this situation. And this is where I might consider things like buspirone, pregabalin, or in some of these patients, perhaps Silexin that we talked about, or even a longer acting benzodiazepine. Now, if that works, great. We celebrate, have that cookie cake, and go forward. However, when it doesn't, we need to think about some of those next line interventions. There's a class of medicines we didn't talk about much, but those are the tricyclics, but we also have monoamine oxidase inhibitors and others. So summarizing, the importance is really recognizing and identifying the correct diagnosis for the anxiety disorder early on. And then thinking about the treatment approach that we've already described. And then really probably most importantly, as we unfortunately just got to on the last slide, is making sure that we're tailoring treatment based on non-response, partial response, residual symptoms, responsive symptoms, etc.
Great, and we would tailor the potential risks of the treatment to the severity of the anxiety symptoms. So in milder forms, we would start always with psychotherapy, although it's not always available everywhere in the United States, but there are apps now. You can have this meditation kind of courses that can help you to fall asleep better and calm down. You may need more specific individual treatment, but medications can also be helpful. If it's helpful, it might need to be continued for a year, but deprescribing should also be tried at certain points in people's lives, because as they build their own capacity and also skills, they may not need antidepressants or anti-anxiety medications.
Absolutely. And I think that's such an important point. We actually have a book coming out in January, The Deprescriber's Guide, that focuses on this question that we often don't ask. Does this treatment still need to be continued? And importantly, how do I stop this treatment when I need to do so that I can monitor for relapse or withdrawal symptoms? And how do I differentiate withdrawal symptoms from relapse?
Wonderful. I mean, we're almost coming up to the top of our 45 minutes. If there are any questions by the audience, please submit them. Otherwise, I think we've really covered a lot of ground. And thank you so much, Jeff. This was fantastic as expected. And maybe, Ran, you want to end the session with some words about also what we can expect next?
Sure. Oh, thank you so much. A huge thank you for Dr. Sean and Christoph to have such a rich and insightful conversation. Of course, thank you to everybody who joined us today. We really appreciate the time and the presence. If you would like to have continuous conversation with us, feel free to connect with our social media page, LinkedIn page, and share your questions. And that's it. Until next time. Have a good rest of your day, and thank you again for being here.
Thanks, Jeff. Thanks to the audience, and we'll be in touch with Medlink Global News very soon again to improve healthcare. So thanks so much, everyone. Take care.